Respiratory distress, or in simple terms, breathing discomfort, is frequently encountered amongst patients in the emergency department and the wards. It could be a manifestation of one or more cardinal organ dysfunction in the system, such as the heart, lungs, brain, or metabolic abnormalities. As a house officer in the medical department, you should be able to identify signs of respiratory distress and arrest. You are also expected to act quickly by alerting your medical officer or physician in charge while initial bedside measures are being carried out to assess the severity of the disease. Here we will look at a workflow process of an approach to respiratory distress as a house officer. By the end of this session, you should be able to define respiratory distress, explain the mechanisms of dyspnea, outline an approach to a patient with respiratory distress, describe the life-threatening causes of respiratory distress, and interpret an arterial blood gas. Let's get started. So the mechanism of dyspnea actually begins with the sensation. So there are a couple of receptors in the body that triggers the respiratory centers, and these are chemoreceptors, which are located in the carotid bodies, the mechanoreceptors, which are located at the skeletal muscles, and the metaboreceptors. Stimulation or trigger of these receptors then sends a signal to the respiratory centers, which then initiates increased respiratory drive. The effector for this would be the motor cortex, where it then sends signals to the ventilatory muscles to increase ventilation. Now, let's look at a stepwise approach on approaching a patient with respiratory distress. We will always begin by verifying the symptoms by the patient's own words. Attend to the correct patient and verify the name. Ask the appropriate questions such as, "How are you feeling? I was informed that you are having difficulty breathing." Many a times, patients are breathless to answer your questions in entirety. So use this opportunity to assess the patient's respiratory rate and capacity of saying words, as this is a subjective manner of determining how breathless the patient could be. Was the breathlessness sudden or progressive? Did it occur at rest or exertion? Do you have a bad cough, feeling wheezy, having blood streaks in your phlegm, chest tightness or pain, difficulty lying flat, or gross leg swelling? Do you have any history of allergies before? These questions are triggered to look out for associated symptoms which could provide you an extra clue to what may the cause be. Next is to verify and correlate the signs. Look at the patient's general appearance, whether the patient is restless or agitated, sweating, using accessory muscles to breathe, or cyanotic. Reconfirm the GCS. If it's full, it means he was able to answer your previous questions. If not, it means the patient was not able to have good eye contact or response or verbal response that could be possibly due to drowsiness. Gather the patient's vital signs as the nurse places the monitors on the patient. Blood pressure, the heart rate, regularity, symmetry on both arms, oxygen saturation, respiratory rate, and the temperature. Examine the main areas. Look at the neck to look for raised jugular venous pressure, which is seen in right heart failure or cardiac tamponade. Examine the chest to listen for heart sounds, abnormal sounds like murmurs, crepitations, rhonchi, reduced or absent breath sounds. And look at the lower limbs to examine for swelling. If swelling is present in both lower limbs, consider heart failure. If one of the limb is swollen, you may want to think about deep vein thrombosis. Next, let's look at bedside tests. These are tests done with the help of the ward nurses or your colleagues on the ward. At least one large bore intravenous cannula needs to be inserted. A 12-lead ECG followed by serial ECGs are important. At least 3 ECGs done at an interval of 5 to 10 minutes. Oxygen supplementation is then provided based on the oxygen saturation seen on pulse oximetry. Don't forget to insert a urinary catheter to measure the patient's urine output in the case of heart failure. This is a flow on oxygen supplementation therapy. It is referenced from the British Thoracic Society guidelines. Begin with titrating oxygen up or down to maintain the target oxygen saturation. This flowchart shows the available options for stepping dosages up or down. The chart does not imply any equivalence of dose between venturi mask and nasal cannula. Allow at least 5 minutes at each dose before adjusting further upwards or downwards, except with major sudden fall in saturation, which is more than 3%. Once your patient has adequate and stable saturation on minimal oxygen dose, consider discontinuation of oxygen therapy. Seek your senior's input as soon as patient requires more oxygen. Let's look at instant lab tests that could be done. These include cardiac enzymes such as CKMB or high specific troponin I. If raised, this most likely could be an acute coronary syndrome. Not forgetting portable chest x-rays to look for pneumothorax, pneumonia or widened mediastinum. An arterial blood gas sampling is done to assess oxygenation and severity of respiratory failure or acidosis. Other blood tests is done to send if there is evidence of temperature spike more than 38 degrees, and these include full blood count, leukocytosis present would indicate infections, a reduced HB would indicate anemia, a C-reactive protein that's high would suggest bacterial infections, and blood cultures are to be done to identify microbe and sensitivity. It's done before escalation of antibiotics as well. After confirmation by the medical officer, if high suspicion of pulmonary embolism based on the Wells score, you'd want to consider running a D-dimer. If it's low or negative, it's unlikely to be a pulmonary embolism. However, if it's positive, you may want to then proceed with a CT pulmonary angiography. Stay with the patient until your medical officer arrives. Then you may expedite the transport of blood samples to the blood lab while ensuring there's always a doctor by the patient. Always reassess the patient with repeat of the steps shown earlier after measures have been taken by the medical officer. Your medical officer or physician or surgeon attending will decide the initial treatment to be given based on the information from the tests done. You will also be informed to alert the anesthesiology team for escalation of care, such as if there's indication of requirement of non-invasive ventilation, CPAP or BiPAP, or invasive ventilation, as initial measures are performed by your medical officer. Now let's take a look at the causes, life-threatening causes of respiratory distress. We have anaphylaxis, exacerbation of an underlying existing lung disease, pulmonary embolism, cardiac causes such as acute pulmonary edema, cardiac tamponade or valvular dysfunction, pneumothorax, pneumonia, and metabolic acidosis, which gives rise to Kussmaul's breathing. Now let's take a look at an arterial blood gas interpretation. This is a flow chart on how to interpret arterial blood gas. First, determine if it is an acidosis or alkalosis based on the normal pH values as shown on the table. In acidosis, determine if it is a respiratory component or a metabolic component by looking at the carbon dioxide and the bicarbonate levels. If the carbon dioxides are high, which means the carbon dioxide can be converted to carbonic acid, causing increased acidity in the blood, now that would be a cause of respiratory acidosis. If the bicarbonate levels are low in the system, that would be indicative of metabolic acidosis. Similarly, in alkalosis, determine if it is a respiratory component or a metabolic component by looking at the carbon dioxide and the bicarbonate levels. By the end of the interpretation, you should be able to identify if the patient is in respiratory or metabolic acidosis or alkalosis. Take note, in a normal pH level, always look out for the carbon dioxide and the bicarbonate levels as well, because it could be a state of compensated respiratory alkalosis or metabolic acidosis. We have come to the end of this session. Thank you for your time.